Introduction, anatomy, etiological classification, clinical presentation, right heart assessment and risk stratification in TR, medical and then guidelines indications, surgical management, transcatheter tricuspid valve interventions and algorithms, and then our experience. Introduction. First of all, definition of TR. It's nothing but inadequate leaflet coaptation during ventricular systole leading to LV2, RV2, RAJ. It leads to reduced forward stroke volume despite reduced increased total RV stroke volume. RV ejection fraction may appear normal or increased due to volume overload. And clinical impact of TR is minimal or trivial TR, often benign in normal valves. Even mild to moderate TR linked to 29% increased mortality versus no TR. Prevalence and demographics. Prevalence about 1.5% in men and 5.6% in women, and then increases with age. Historical perspective, TR treatment often ignored previously, assuming left heart disease treatment would resolve TR. And then some cases of tricuspid valvectomy acceptable in IV use related endocarditis previously gave hope that RV is a passive conduit, need not be tricuspid regurgitation need not be corrected. But clinical importance is that severe TR, once considered benign, now recognized as a strong predictor of poor prognosis. Isolated moderate to severe TR survival rates are only 72% at 1 year and 47% at 5 years. 90% of the patients remain undertreated despite poor outcomes. Challenges in management are that symptoms are non-specific and are often attributed to other diseases, and then medical treatment like diuretics and managing left heart disease, pulmonary hypertension remains primary. Surgical treatment often delayed and late intervention linked to high in-hospital mortality reaching 10%. So emerging solutions like development of transcatheter treatment, treatment devices to reduce surgical invasiveness and lack of clear guidelines on optimal timing and patient selection for intervention. Coming to tricuspid valve anatomy. Anatomy, if we see general features, largest and most apically positioned valve in the heart is the tricuspid valve. Normal orifice area of around 7 to 9 centimeters square. Normal annular shape is non-planar D shape. And area around 11 and diameter 28. Normal annular systolic reduction during systole is 25% and TAPS is 16 mm. Tricuspid annular plane systolic excursion TAPS. And then annular dilatation and TR highly annular dependent. Significant TR occurs with only 40% annular dilatation, versus if we compare it to the left side, it is around 75%. Slightest annular dilatation will cause severe TR or significant TR. Coming to the leaflet anatomy anterior, which is the largest, it is quadrangular and greatest mobility. Posterior leaflet is smallest and triangular and may be fused with anterior, sometimes in around 10% of cases, and septal leaflet is semicircular, least mobile, attaches above interventricular septum. And we can see the fibrous skeleton of the heart diagram here, which in which we can see the relation of the heart. Which is the septal leaflet or anteroseptal commissure is near to the non-coronary cusp of the aortic valve, and then anterior cusp is little far away from the right coronary artery, and coming towards the posterior side or posterior leaflet side, it is coming way closer to towards the leaflet. And the pathological changes, reduced leaflet coaptation cause TR. Symmetrically, if it is reduced coaptation means it will cause central TR. If it is asymmetrical, it will cause eccentric TR. Usually 90% of the cases will have a normal leaflet morphology, but other cases can have other morphology with leaflet number with ranging from 3 to 7. So type 1 is the classic 3 leaflet morphology, which we can see here, and then type 2 is 2 leaflet, where the fusion of anterior and posterior will happen. Type 3 is 4 leaflet, in which there are some subtypes 3A, 3B, 3C. Type 4 is more than 4 leaflets, and morphologic complexity may influence outcomes in transcatheter edge-to-edge repair, where this is more significant or more relevant. So key adjacent structures around it we already saw editing. So non-coronary sinus of Valsalva, which will be there in this area near anteroseptal commissure, and AV node is this is the triangle of box with coronary sinus, septal area to the tricuspid valve, and then the ponderum, which the apex reaching near this area where the penetrating bundle and AV node will be existing. So this is 3.5 mm posterior to anteroseptal junction, and then right coronary anatomy. Right coronary will go around like this, with around 8.8 centimeters from the anterior leaflet here and 3.6 centimeters from the leaflet here. And papillary muscles and anterior papillary muscle and then posterior papillary muscle. Anterior is the largest, connected to moderator point also, which you know, and then posterior papillary muscle supports posterior and septal leaflets. Septal one is the smallest one and often absent also, with chordae arising directly from the septum. So caudal types, normal according to the mitral anatomy, it's like same, primary and secondary and tertiary. Classification of tricuspid regurgitation according to the etiology. So this is etiological classification, which we most of the times call every tier as a secondary tier. Secondary tier. So secondary tier is again divided into two types. Apart from that, there is primary tier, which means that intrinsic tricuspid valve leaflet or subvalvular disease is there. And then secondary tier, atrial secondary tier, and ventricular secondary tier. Atrial secondary tier is ASTR, ventricular secondary tier with VSTR. Atrial secondary tear happens in patients of chronic AF, which will cause RA dilatation, which will cause annular dilatation, which will cause tricuspid regurgitation. So, RV remodeling is not in the initial stages. And then ventricular secondary tear is due to LV, which have the effect on pulmonary vasculature and then pulmonary arterial pressures and then RV dilatation and then leaflet cluttering and then non-coaptation of the leaflet, which will cause initial changes in the RV, not in the RA and in the annulus. So these morphologically different these things we can see in a CT 3D reconstruction images. So where A is atrial secondary tier, which we can see RV is preserved with RV is of normal morphology, but we can see RA is severely dilated, and then ventricular secondary tier we can see RV is dilated as compared to the RA. During the later stages of both atrial and secondary tier, it will be dilated like everything will be dilated. And then the third one is cardiac implantable electronic device related tier, CIED. So morphological differences is that ventricular secondary tier RV dilatation will be in the mid ventricle, which will cause leaflet tethering, will come malcoaptation. Atrial secondary tier, prominent RA and annular dilatation. Talking in respect to primary tier, which is around comprising around only 5 to 10% of the cases. So mostly it can be congenital or acquired. Congenital, we know it's substance anomaly or a cleft AV valve in other cases, and then acquired degenerative, that is prolapse rheumatic heart disease, which is very rare now towards tricuspid valve, and then infective endocarditis, which is becoming more common nowadays, and then carcinoid heart disease, which will give fibrinous degeneration of the carcinoid heart, carcinoid syndrome, and then tumors, trauma, or iatrogenic. In a single center data, which is showing in the recent studies, endocarditis comprising around 47, degenerative or prolapse is only 18.3, and prosthetic valve failure also comprising now around 16.8%. So tricuspid valve endocarditis worse prognosis than degenerative. Talking towards the secondary functional tier, greater than 90% of the cases. So mechanism, as we already explained, that it's due to pulmonary hypertension or left heart disease. Main etiologies are left heart, atrial dysfunction, and then pulmonary disease, 17%. Outcomes, pulmonary arterial hypertension, worst prognosis, and atrial tier, more common in females linked with AF and heart failure with preserved ejection fraction. Ventricular tier, generally worse outcomes than atrial tier. Cardiac implantable electronic devices related here, incidence is around or prevalence is around only 0.5 to 5%. In CIED implantation cases, up to 39% will have some tear which is relevant to the tear pathogenesis. And the mechanism is lead interaction with the tricuspid valve leaflets. Direct damage is very rare, less than 3% only. Management is lead removal, improves in TR in around 35% of the cases. Improved valve function and extension has showed the results that there is reduced mortality. So LTRA, lead related TR has again two subsets like LTRA and LTRB. A is causative one, B is incidental one. So while evaluating, we have to keep in our mind these points that primary tear, secondary tear incidence, it's but a primary tear, right atrial size, left atrial size, tricuspid annular size. So in comparison to each of these, we can actually guide the management principles, whether it is related to whether it is repairable or not. Clinical presentation, early stages, isolated tear. In isolated tear in early stages usually asymptomatic, progressively moderate severity, fatigue and exercise intolerance due to reduced cardiac output, and then RV volume overload leads to progressive RV enlargement. And then central venous congestion symptoms starts, lower extremity swelling, abdominal fullness or discomfort, pulsatile neck sensations. Physical signs as peripheral edema, bowel edema, ascites, subsplenomegaly, and jugular venous distension with prominent V wave. TR with preceding left heart disease will be preceded with pulmonary venous congestion symptoms like dyspnea on exertion by PND and arrhythmia. Late stage severe will have combined central and pulmonary venous congestion. Severe RV dysfunction, low output RV failure, marked fatigue and progressive disability. And then last cardiac cachexia and renal and hepatic dysfunction with end organ dysfunction will start. Coming to the assessment of the right heart. So RV physiology and function depends on intrinsic contractility and loading conditions like preload and then afterload. So TR impact is like high preload, large RV stroke volume can mask reduced RV contractility. Increased afterload, RV compensatory contractility eventually fails, then RV to TR uncoupling will happen. The comprehensive RV assessment preferably should be done in euvolemic state, and then non-invasive models will have speckle tracking echocardiography, disease tissue doctor imaging, and then 3D echocardiography, CT, and MRI. So transthoracic echo or transesophageal echo, the points which we have to see towards the tricuspid is that evaluation of RV is TAPSE and tissue Doppler integral, and then RVEF stroke volume, and then RV global and free wall longitudinal strain. And then the one ratio that is TAPSE by systolic pulmonary arterial pressures ratio, SPAP. Diagnosis of pulmonary hypertension by SPAP, usually through echocardiographic values we will see. And then contractile reserve by stress imaging. And then under stress, we will see is there any increase in TAPSE, so that we will come to know is there any reserve left in the RV. And then CT and MRI. CT will give us volumetric measurements, and MRI will give volumetric measurements and strain analysis. Assessment of myocardial fibrosis also through late gadolinium enhancement and extracellular volume. Contractile reserve by stress imaging both in CT and MRI. And right heart catheterization is the last that will give us the diagnosis of pulmonary hypertension, that is SPAP, and mean pulmonary arterial pressures, and then the most prognosis value, that is diastolic pulmonary arterial pressures. Pulmonary vascular resistance and evaluation of the RV function, that is transpulmonary gradient and RV stroke work. So right heart catheterization is the gold standard to give all these values, provides pulmonary hypertensive severity, and then RP preload and afterload with vascular resistance. Three predictors of poor outcome after tricuspid valve repair is if mean pulmonary arterial pressures are high, it's a poor outcome, and then increased diastolic PA pressures and increased transpulmonary gradient, increased pulmonary vascular resistance, and decreased RV stroke work. Additional risk stratification tools are cardiopulmonary exercise testing, CPET, and myocardial fibrosis detection through MRI or speckle tracking. So we have to know one term, that is this RV to PA coupling. So RV to PA coupling is that it describes that RV function, that means contractility, and its ability to adequately handle dynamic loading volumes when pulmonary pressures change. That is RV afterload. That means RV contractility dynamically changing according to the pulmonary arterial pressures. That is RV afterload, expressed as the ratio of tricuspid annular plane systolic exertion to RV systolic pressures. So TAPC by RSVP is the RV to K coupling value, which actually, if it is less than 0.04, is an independent predictor of increased all-cause mortality. One more is pulmonary arterial pulsatility index. This is RV systolic pressures minus PA diastolic pressures by RA pressure. So here indirectly, if the pulmonary arterial diastolic pressures are high, it will be having a poor prognosis, and we can actually see we calculate the values if we have some right heart catheterization values. In the RV free wall longitudinal strain and then RV fraction area change. And these are all the parameters which we can see for an comprehensive RV evaluation. So right ventricle, according to all this CT, MRI, echo, we can get all these things, and cardiodynamic and hemodynamic profile with which we usually don't do, but if it is indicated, we can do cath to get all these values, and then clinically we have to see all these values, and then end organ we have to keep in mind glomerular filtration rate is more in correlation with the prognosis. So glomerular filtration rate less than 30 ml per minute and elevated total bilirubin are poor prognostic factors. Then LVF 60%, less than 60%. Operator risk stratification in TR. So TR patients often high risk due to comorbidities and RV dysfunction. Right heart physiology and hemodynamics are key, but additional parameters improve stratification. This risk stratification will help us to predict in-hospital mortality, and then risk analysis, and then morbidity after surgery. Major operative risk scores we have already, that is STS-TV score, which has age, sex, and previous stroke, hemodialysis, and lung disease, NYHA, reoperation status, and urgent emergency surgery. Keeping the parameters what it is combining, but we have a score which is operative score, which is ranging from 0 to 10 plus. Higher the score, higher the mortality and morbidity. And we have other scores like TRI score, which is also having 8 parameters, which is also in a hospital outcome of that isolated tricuspid valve surgery. And then functional disease staging, according to this thing, according based on this end organ involvement, medical therapy requirement on this right heart failure episodes, functional disease staging has proposed a staging of 5 stages, which we will tell later, and then not validated for transcatheter tricuspid valve interventions. All these risk scores are for in-hospital operative mortality or operative outcomes or risk stratification, not for transcatheter interventions. So 5 theoretical stages are stage 1 to 5. One is symptomatic with moderate ER. Second is symptomatic mild to moderate. Minimal RV remodeling. Stage 3 is significant TR with RV dilatation and dysfunction. Stage 4 is severe TR with the recurrent right heart failure, hospitalizations, and under-organ involvement. Stage 5 is torrential with overt right heart failure despite optimal therapy. So no specific cutoffs which will guide the timing of intervention, but introduce the concept of early versus late presentation. Coming to the medical management. So medical management, early stage compensated TR hemodynamics are preserved due to RV compensatory remodeling. So in that stage, usually no medical therapy required. And but RV adaptation limited as compared to the LV, compensation is short-lived. Progression to symptomatic TR, RV dilatation increase central and pulmonary venous congestion cause symptoms like dyspnea on exertion and then orthopnea, peripheral edema and all. So RV free wall dilatation will cause spherical RV geometry and progressively will cause dysfunction. Advanced chronic tear, the same vicious cycle will continue and then endorphin development will start with hepatorenal condition. So pathophysiologic changes over time. Initially, RV will be adapting, maintaining forward flow, and then maladaptive remodeling will cause RV dilatation and papillary muscle displacement, which will cause tear, which will eventually lead to refractory right heart failure. And then management actually, medical management is usually supportive management only, which we have to optimize the patient medically before taking him for surgical or catheter intervention. So symptom control, usually people, we have to use diuretics, loop diuretics along with some endocorticotrophs like spironolactone or epinephrine, and then non-pharmacological measures are sodium and fluid restriction and compression garments for peripheral edema. Etiology specific approaches is we diagnosed previously, then ventricular secondary TR with optimized pulmonary arterial capillary wedge pressure, so this is before transcatheter therapy. Atrial secondary TR usually caused by atrial fibrillation, where we have to do rhythm control, and cardiac implantable cardiac implantable electronic devices, we have to revise the lead or extraction if possible. So at last we have class 1. For except for EF, we use drugs like beta blockers, ARNI, SGLT2 inhibitors, and mineralocorticoid receptor antagonists. And then for HPFEF, HFPEF, SGLT2 inhibitors, and then MRA can provide benefit. In acute decompensated heart failure, we will need hospitalization and IV diuretics, vasomodulators for BP, and then mechanical, circulatory, and ventilatory supports, which is the last stage. Guidelines for tricuspid valve interventions. So, general principles, most guidelines recommendations apply only when left-sided heart surgery is planned. So, timing of isolated TR is controversial. Too late means irreversible RV and organ damage. Too early is like taking unnecessary risk. So, goal is to intervene before irreversible RV failure and organ dysfunction starts. When TR surgery is performed with left-sided valve surgery, so both AHA and Canadian classification, European classifications will tell like class 1 is both guidelines will tell severe TR due to left-sided valve surgery during left-sided valve surgery. Class 2A, according to ACC, is mild to moderate TR with annular dilatation. That is annulus greater than 1440 mm or greater than 21 mm by meter square. According to the surface area, it is more reliable, and the prior right heart failure symptom times during right left-sided surgery. So coming to ACC or AHA 2020, AHA goes towards more conservative ways in a way that only class 2 will have symptomatic right heart failure. Either it should have symptomatics or and no pulmonary arterial hypertension or no severe RV dysfunction should be there. And then class 2B is asymptomatic primary severe TR with a progressive RV dysfunction or dilatation. Symptomatic right heart failure and severe TR often after prior left heart surgery without pulmonary hypertension or severe RV dysfunction. So either we have to take symptoms into consideration or into pulmonary hypertension and severe RV dysfunction. These two should not be there and the symptoms should be. Coming to European Society of European Guidelines 2021, European guidelines are more towards earlier intervention supported. So class 1 is severe symptomatic TR without severe RV dysfunction, and class 2A is Asymptomatic or mildly symptomatic severe primary or secondary TR with RV dilatation. No severe LV, RV dysfunction or pulmonary hypertension. Class 2B transcatheter therapy for symptomatic secondary TR in inoperable patients that experienced heart valve centers. So European guidelines added 2B for transcatheter therapy, where in AHA there is no such provision for transcatheter therapy. So timing considerations are late symptoms. Advanced RV with organ failure will have worse outcomes. So isolated tricuspid valve surgery, it is very rare. Only 14% have isolated tricuspid valve surgeries. Historically, a high in-hospital mortality with all previous studies, it is ranging from 8.8 to 37% in-hospital mortality, with the 55% mortality at 5 years. Poor outcomes are morely due to late referral with advanced symptoms, and then early stage surgery is showing better outcomes evidence, low in-hospital mortality, and 5-year survival is 100%. Surgical repair versus replacement. Preferred is tricuspid valve repair. Goal is to reduce annular size and restore normal valvular anatomy. Techniques is ring annuloplasty, which is gold standard nowadays. Suturing annuloplasty, which we have case bicuspidization and digital technique, and leaflet techniques, like clover leaf or leaflet augmentation. Benefits of ring annuloplasty versus sutures is that better long-term survival and fewer reoperations, improved event-free survival. Tricuspid valve replacement will happen only around 10 to 15% of the cases. In very extreme cases where extensive leaflet destruction, like in cases of endocarditis, rheumatic or iatrogenic, and secondary TR with severe leaflet tethering and massive annular dilatation. So these are the predictors of annuloplasty failure. Tethering height more than 0.5 centimeters and tethering area more than 0.8 centimeters square, annulus more than 44 meters. Concerns with the tricuspid valve replacement is that 33% need permanent placemaker implantation post-op, which will actually make the prognosis even worse. Prosthesis choice in tricuspid valve regurgitation is mechanical versus bioprosthetic. Studies are showing similar outcomes, but people are tending towards tissue valves, thinking of future transcatheter valve in valve procedures. So coming to surgical intervention for tricuspid valve disease, three fundamental principles, like left side mitral valve, the same restore or preserve full leaflet mobility, provide a large surface area for leaflet coaptation, remodel and stabilize the annulus. So the tricuspid annulus is measured comparing its size with the surface area of the valvular tissue in order to assess the presence and severity of annular dilatation. So surface of the valvular tissue, while insufflation test, we have to see and then measure according to it. So types of tricuspid repair actually depends on the type of regurgitation which we have. According to the Carpenter's classification, the same type 1, type 2, type 3, that one only. So type 1 is due to annular dilatation. If it is, then ring has to be selected. So the ring has to be selected. The first is the measurement of the base of the septal leaflet, which is not significantly affected by annular dilatation. That will actually guide us how to select the size of the tricuspid annulus. And then second one is the most important measurement is the surface area of the leaflet tissue attached to the cardia arising from the anterior papillary muscle. So I will show here. So anterior leaflet, posterior leaflet, and septal leaflet, which we can see here. We have to go around the anterior papillary muscle, stretch it, and then see the height of the leaflet tissue, and then measure. Then ring implantation in tricuspid valve. The first septal suture should be placed posterior to the midline of the septal leaflet through the very hinge of the leaflet to prevent injury to the bundle of face. So the first stitch is the more important stitch, which we will go carefully. And for the here we can see the two horizontal areas we will be going forehand. Two vertical areas we will be going forehand, and two horizontal areas we will be going backhand. Again, it's a surgeon's preference. So type 2 TR is extensive prolapse resulting from bacterial endocarditis or from traumatic. So requires resection like in EA, and then restoration of the leaflet continuity by annular plication and leaflet suturing like in B, and then C is putting a patch sometimes. This is mostly for the isolated leaflet prolapse. The other one is extensive caudal rupture, which we will repair by putting artificial cording and then stabilizing the angles. Type 3 tricuspid regurgitation. Commissurotomy of the three commissures is performed under direct visualization with the division of the fused cardi. And then further leaflet mobilization is achieved by resection of secondary cardi. When the leaflets are significantly retracted, leaflet extension is performed after commissurotomy and fenestration of the supporting artery. Normal cusp position is then obtained by insertion of the prosthetic ring. So, fused cardi should be removed, and then a leaflet extension can be done by using a pericardial patch. Coming towards the suture annuloplasty, devices, which is the most famous one, and then no more than moderate tear we should be using devices technique. Should be used around mild to moderate tear. It is designed to narrow the tricuspid annulus at the base of the anterior and posterior leaflets, avoiding the area of the penetrating bundle of his and atrial membranous septum. The suture is tightened until the orifice will admit an appropriate size around 24 to 30, and then is tried. Devigas technique, which has the advantage of not using prosthetic material, but the inconvenience of being narrowing it in the annuloplasty and not restoring a normal shape of the annulus is the function. Long-term function is not dependent on integrity of the repair. Bicuspidization technique is to shorten the circumference of the tricuspid annulus by simply excluding the part to which the posterior leaflet is attached like this. So using 2 or 3 polyester suture is passed through the annulus and the anteroposterior commissure, then in center of the posterior leaflet, and then through the annulus to the posterior septal commissure. The suture is tied snugly, and the second one is placed for reinforcement. Coming to replacement, when the tricuspid repair is not feasible, tricuspid replacement is attempted. The leaflets are excised, and then 2 to 3 mm of fringe of leaflet tissue is left on the annulus. Starting at the midpoint of the septal leaflet cuff, interrupted horizontal macro sutures. First placed into the remaining valve tissue and then through the sewing ring of the replacement device. After placing 4 or 5 interrupted mattress sutures, remainder of the insertion is completed using a continuous suture technique. Bites may be through the annulus, mindful that the right coronary lies deep in the annulus anteriorly. Coming to transcatheter interventions. Transcatheter interventions are transcatheter tricuspid valve interventions are emerging now. Types of transcatheter tricuspid valve interventions now available are leaflet coaptation devices like mitral clip, Tricuspid, annular repair devices, and heterotopic cabal valve implantation and orthotopic transcatheter valve implantation (TTVR). So, using these devices, clinical outcomes show reduced TR period and symptomatic improvement is there, and decreased hospitalization, decreased on-air mortality, and reverse RV remodeling. Increased cardiac output and reduced liver enzymes. So current data is all from retrospective studies. Randomized control trials need confirmation. Timing and patient selection is critical. And predictors of poor outcomes is as the same all stage 5 diseases. So transcatheter edge-to-edge repair (TEER), most widely used technique for tricuspid valve repair, more complex than mitral TER due to multiple leaflet coaptation lines and then far field imaging challenges. This imaging is difficult, and then due to multiple coapting lines, the results are more varied. We have 2 devices, one from the Edwards and one from Abbott. Abbott one is Triclip G4, which we have some morphological changes between these two, more or less like mitral clips. Next one is annular repair devices developed to overcome TER limitations, focus on reducing annular dilatation and improving leaflet coaptation. So the one available is cardio band system from Woods, implanted via transcatheter annuloplasty, requires echocardiography plus fluoroscopic guidance, anchors placed along the annulus between leaflets and right coronary artery. Advantages is that preserves native valve and allows for future interventions like leaflet repair and valve replacement. Limitations is high imaging demand, limits widespread adoption, excessive annular dilatation cannot be corrected, and large coaptation gaps. Short or retracted septal leaflets reduce efficacy. So next comes the next to overcome all these disadvantages. Next one is the valve replacement devices, that is actually to be placed in the same place, that is orthotopic, and then other in the cava, vena cava, that is heterotopic.
Yeah.
So heterotopic devices are palliative, which we have trick valve and then tricontrol, and then usually these all these things used in inoperable and symptomatic patients just as a measure of palliation, but this is relieve venous congestion and TR symptoms. There will be reduced. There will be difference in the pressure gradient between vena cava and then RA. Orthotopic devices are anatomic replacement, evacuate TVR, Luxwell, cardiovalve, and interpret. Uh, Moving ahead, this valve in valve and then valve in ring is also feasible. Valve in valve is like doing it for aortic valves as they are doing, and then valve in ring usually previously ring whichever we place is an incomplete ring, so there is a risk of residual leak and then impaired leaflet function. Here we can see the images of different valves in different heterotopic and orthotopic valves in their positions. Cardio valve, Lux valve, and then this is in the IVC, and then this is in the SVC. So severe symptomatic TR, according to the diagnosis, whether transcatheter valve repair is feasible means it can be done, or if it is not, then transcatheter valve replacement can be done. Coming to algorithm, so first one is isolated TR without any left-sided heart disease. If we find a TR case which is severe TR without any left-sided valve disease, so or concomitantly if we are not doing left-sided valve surgery, then severe primary TR which is symptomatic. If it is symptomatic, then we have to do tricuspid valve surgery, repair or replacement. And if it is not symptomatic, then we will see towards RV dilatation or early RV dysfunction, and then evaluation for and then evaluation according to the heart team. And if they suggest for surgery, then surgery can be done. If it is not appropriate for the surgery, then it will be then can be sent to tricuspid valve transcatheter intervention. And then secondary TR, which is not having severe RV dysfunction, or if it is not having any symptomatic, then it will go towards medical therapy. And then late presentation or advanced disease also will go towards medical therapy. And then tricuspid regurgitation with left-sided valve surgery. Severity is non-severe TR or tricuspid annular dilatation, and moderate or progressive primary TR, severe primary TR, and all this will go towards a tricuspid valve repair. Should be performed to be performed. If there is no right heart failure symptoms and if the TR is only less than mild or mild, then no concomitant tricuspid valve surgery required. Coming to transcatheter interventions, if the severe TR, severe secondary or primary TR with late presentation, we'll go towards medical therapy, which no one touches. But if there is somehow that severe secondary TR with small coaptation gap and central coaptation gap is central, then we can then can be referred to TER and extensive coaptation gap, then orthotopic transcatheter tricuspid valve replacement and small coaptation gap, commercial jet location, mild to moderate tethering, prolapse or fail, will go towards TER. Leaflet restriction or perforation will go towards orthotopic tricuspid valve replacement. And then coming towards our experience in NH, I'm going to 2024 statistics. Total tricuspid valve surgeries around 133 with ASD closure plus MVR plus TVR. Around 5 ASD closure plus tricuspid valve repair is around 10. These are congenital, which is flow related and then coming to the secondary tiers. So secondary tiers we have DVR TV repair, CABG with MVR TV repair plus PVA. All these things which will go towards the major proportion, and then isolated triage repair surgeries are very less in number, where some TRs which are left during previous left heart surgery will come back for tricuspid valve surgery, which is redo TV repairs are 6, and then primary TV repairs for other causes are 8. Coming to age distribution, female around 75, that is around 56.39, male around 43.6. Average age around 45.96. The proportion of cases which we can see here, major one is the MVR TV repair plus or minus LA thrombectomy. Next one is DVR TV repair. Remaining everything will comprise other. If we take towards wider statistics comprising around 66 years, that is from 2016 to 21, total around 594 cases, where we have included cone also. So Epstein's anomalies are around 91, which we can put it aside. Other than that, USD plus tricuspid valve repairs plus or minus mitral valve repairs are around 28. All these things are secondary tiers, and then redo TVRs. TV repairs are 15 and TV repair primarily are 24. Here also we can see MBR TV repair is a major one, and then next one is the cone repair for Epstein's anomaly. Remaining next one is DVR TV repair. Remaining all are redo MBR TV repair, redo tricuspid valve repair, and redo DVR TV repair. So these are my references apart from standard textbooks. Thank you.
Okay, thank you, Mohan. The main crux of your entire talk should be for you as surgical trainees and practicing surgeons later on is when to intervene for tricuspid regurgitation and when not to intervene for tricuspid regurgitation. So that is what you have to make a clear-cut idea in your mind, how, when, and how. So the simplest thing is to learn in all these, most of these guidelines, they give you class 1, class 2, 2A, 2B, 3, 3A, 3B, and all sorts of things. To simplify for you people to understand and remember is you must know class 1 symptom where it is definitely indicated, and 3 where it is harmful. So if you know these two, the in between one is controversial, and that you can probably look back and then do some reading and then decide whether to do or not to do in individual cases. So class for basic idea, you should know class 1 and class 3. So primary indication definitely needed and definitely not needed. So this is how it is easy to remember, and even when somebody asks you a question in the exam, it is easy to answer that. Okay.
Yes.
So Rahul is there. I can see. Good morning, Rahul.
Morning, sir.
You have any comments to make?
is covered quite extensively. I just want to ask Mohan in one, probably in one, like like the moral of the story, like what Sir said. When would you intervene? When would you not intervene? Like a real life scenario we have most of the time. We will have mitral valve disease
Mitral
with
valve
the
disease
TIA.
with the tricuspid regurgitation. Mostly, we have to assess for the PA pressures and then annular measurements according to
So
the
what
body
is an
surface
annular
area.
cutoff? Just to revise them.
It is like more than mild intervening, you will have the good prognosis according to the this thing.
More
See,
than
mild, moderate, severe is a very vague thing. You must have numbers to say that, okay, this is mild, this is moderate, this is severe. So somebody's mild can be other person's moderate and things like that. It is very vague. So you must have a clear-cut idea in this condition we will do, and this measurements we will not do. So that should be the criteria from which you will later on, by through experience and also from individual cases, you will decide what to do and what not to do. That is how
like
you
we all
must.
know when we are operating, we will if it is a moderate TR, and
Yes.
you know, we are all guilty of trying to avoid that, trying to avoid addressing the tricuspid valve.
Yeah.
Whether we
Most of
accept
the
that we are
things.
guilty or not of the different matter. Yeah. So we are all surgeons are guilty of trying to avoid touching the tricuspid valve for whatever reason. So
Yes.
most
Yes.
of the time, what happens, we will have a moderate TR on the pre-op echo. Then we'll do a transesophageal echo on table, and it will obviously be mild because it's under the effect of anesthesia.
They will say micro moderate.
So that is the most common practical scenario which happens where we would not want to address. Would one more question I wanted to ask is, what is your opinion about annuloplasty with the Divega and modified Divega, those kind of things?
Just mild plus or mild to moderate is it's okay, sir. But more than if it is moderate or more moderate, I think in long term, Devagas annuloplasty is not recommended. What studies?
There are few important features in Divega annuloplasty, which I'm sure Jaira sir will agree. See, the earlier problems were that they used to use proline sutures, which were this thing, and then sometimes they used to cut through and then cause bowstringing in the annulus. So that was one of the things. So people started using braided sutures like Ethibond or something like that, so that it gets incorporated into the valve leaflet tissue or the annulus, and then sort of become rigid. The second modification was, instead of one single suture going all the way around, they started using two sutures and then using it in between, so that even if one gives way, the other is holding, sort of thing. So these are various modifications that came about with Divega. And then some people use instead of one single continuous suture, they started putting knots in between few mattress sutures, and then like application, and then they started using that. So these are various modifications came about to prevent purse stringing. I mean, bowstringing. Sir, you can elaborate on this, sir.
No, previously we always used to classify as a functional TIA and organic TIA. And we used to ask students, what's the difference between a functional TIA and organic TIA? The organic TIA is where the tricuspid valve is diseased, either by congenital or by acquired. Congenital uh, or by acquired by infection or Carcinoid syndromes, very rarely rheumatic and very rarely degenerating. And those times we knew only functional TIA of the ventricular type because of severe pulmonary hypertension and the RV dilatation. The annulus gets dilated, but the tricuspid valve cusps are absolutely normal. But now they have added a third dimension called the functional or primary and secondary atrial tear. Atrial tear is where the atrium is markedly dilated either due to atrial fibrillation or nowadays they say it gets dilated in a case of heart failure with preserved ejection fraction. And in heart failure with a
Yes.
reduced ejection fraction, there is a RV is also disease and then severe TR occurs. So the and also when you describe little more of the surgical, one of the original techniques was the case annuloplasty, which is bicuspidization, where the posterior leaflet is obliterated by many methods. One of the methods shown is, as you showed, three matter switches on the posterior leaflet to almost obliterate the posterior leaflet. That means you have obliterated the posterior leaflet and the postero-anterior commissure has now come to the posteroseptal commissure. That means complete obliteration of the uh, posterior leaflet. That was given up. One method is by matter sutures. The other method is starting in the middle of the posterior annulus and take sutures, same suture, go round and round till you reach the commissure between the uh, posterior and anterior leaflet, and on the other side between the posterior and septal commissure and tie it so that the now the um, postero-anterior commissure has now come to the posteroseptal commissure. That means we have completely obliterated. That was, I think, given up long time ago. Then we all used to do the Divega was very popular one stage. The basic principle of Divega is that we should start uh, near the septal and the posterior leaflet
Commit.
commissure onto the septal. Little go beyond the posterior leaflet onto the septal leaflet and go all around. Used to be single suture. Go around the posterior leaflet, the anterior leaflet, and the commissure between the anterior and the septal, and go little beyond and tie with two matter sutures. That's a condition where actually, as Krishna said, sometimes the both thing happens. So they started with two switches, one going up to the middle and then the other one. So two switches to the D Vega. Then they started using interrupted projected switches because to avoid the both stringing. Interrupted projected switches between each switcher, all around. So all those modifications have come. But generally, I'm not sure current impression. Generally, the suture annuloplasty is not the best thing to do. I'm not sure what exactly is the current practice in our hospital, but generally it is thought it's better to put a annuloplasty ring, incomplete C type of ring, semi-rigid. That's probably the accepted method for best results. Rahul will be able to tell me what exactly is the current practice. And then of course, I'm not sure about the transcatheter uh, valve insertion. I think there's a lot of complications of heart block 33% or something else. Right? And then transcatheter angioplasty. I'm not sure how do they do that. And then the valve insertion, there are two things they said. As a palliative, either a single valve replacement in the IVC-RA junction or a two valves between the SVC and RA junction and the IVC and RA junction. That's a pure palliative. I don't know whether anybody does it or not. Then you gave a good statistics, but I was a bit disappointed. You didn't tell us what are the procedures done in our hospital. That's the most important thing. You said there's so many procedures are done, but what procedures are done? How many of them you did with a ring? How many of them D-Vega or modified D-Vegas? There are three. At one stage, we used to do with a Teflon felt. Teflon felt
Teflon and Ferricadil felt also.
is measured and cut, and then it's used to do instead of annuloplasty ring. So I don't know. In your statistics, mentioned out of the 554 cases, what exactly you did and what is the current practice. That I would have been happy to know.
Yes, needs more further analysis with each of the OT nodes. It will come up in the future.
Yeah, Rahul will be able to say, what's the current practice of a D-Vega or modified D-Vega and the incomplete ring semi-ridge, what is the currently preferred method,
Sir, actually, most of the surgeons obviously ideally would want to put in a ring, but
Okay.
problem is it comes to obviously finances, and most of our rheumatics are from the low income who come through the scheme.
Yeah.
So whenever the ring is not possible, we do a modified D-Vega. Like different surgeons have different ways of doing it, like what you said.
Yeah.
More often than not, it is like they take at least 2 or 3 interrupted sutures for the D-Vega annuloplasty. Like you said, avoid bowstringing in the future.
Okay.
But it is done. Every surgeon who I've seen who does it is like not very happy doing it, because we very well know in the long term it really may not serve the purpose. But because the patient cannot afford a ring, we are forced to do it, at least to give some kind of relief from the TR for at least for the next few years.
Yeah.
So that is the
That's what
current.
we used to do. We used to do the Teflon strip. I don't know whether they may not be doing it. You said because of the cost factor. Whether it is what is current status or. And also, I'm very curious to know, because we always thought that the replacement of the tricuspid should be with a bioprocess. But in this article, meta-analysis of so many cases, you said there is no difference whether you put a prosthetic valve or a bioprosthetic. What's the current view on that? I don't know.
I don't know the stats in NH, but most of the redo tricuspids, I think even Mohan, you want to add?
Yeah.
No, sir, continue.
Yeah, so most of the either the redo tricuspids, whatever I have seen in my limited experience, has been bioprosthetic. Couple of them I have seen. We have put a metal valve in the tricuspid position.
Yeah.
Some cases are there where in our hospital,
is it Onyx
valve has been used in tricuspid position.
That is Dr. Praveen's patient. I remember that. So for him on follow-up, it's very tricky because you have to keep the INR very high.
Yeah.
Almost up to 4. So because one of them is a very young patient, we are somehow managing. But otherwise, I am not sure how it can be managed, because it's a low pressure situation on the right side. So it is very, very, and especially the compliance on warfarin therapy in our population is difficult, or any population. So
Yeah.
that is one issue, because over time, what happens is when they go back to their villages or towns, they will slowly stop checking the INR.
Mhm.
Initially, it becomes, then they slowly start checking once in 3 months. That is where there's a problem.
Uh, Then I think
Uh,
you said something about the new type of echocardiography, which I didn't understand. The speckle tracking echo to assess the global RV function and also
It's like a
the
tissue
shortening of the
analysis.
shortening LV length shortening and something like that. Is it done here or not?
Yes, sir, it is done here. It is there in a 3D echo mission, which is there in some floors.
What exactly is it? What measurements are you doing there?
Tissue Doppler, the speckle tracking is just like tissue Doppler imaging, sir. Just we have to see the tissue, we have to put that tissue Doppler imaging on the RV muscle, which we will get the contractile function, and then which is like seeing LV in compaction, non-compaction type of thing in the RV.
The
And
take home
other
message
measurements
is, yeah, the take home message
it's
is
like purely subjective, sir. There is no specific number for that. We can just see and then assess for the contractility.
the take home message is that the TR is not as benign as we used to think, that in the long term it has got disastrous results, like the pulmonary valve regurgitation after cytologic correction with a transannular patch. The problem comes after 10 to 15 years. So this is the attention is now on these things, the long-term survival of a tricuspid regurgitation. And also something more you mentioned about the new implants, there is a ICD, implantable cardiovascular defibrillator, all those things also produce TR. So some of them, they may need, you may have to remove the lead and repair the valve. Okay. And then
Yes.
probably put the leads on the epicardium.
Yes.
Okay.
Okay. Right. Thank you, sir.
Thank you. Thank you very
All
much.
right. Thanks, Mohan.
Thanks,
Thank you,
Rahul.
sir.
Bye.
Thanks, Rahul.